Diabetes, or DM, is classified into two types. We have a type 1, which we call juvenile diabetes, and type 2, which was the focus of our study in the women that we studied. The global prevalence of diabetes mellitus in 2022, about 4 years ago, was estimated at 800 million people, and survival among persons with DM has over the years improved substantially because of the better care that patients or persons with diabetes mellitus receive today. Women were the focus of our study, and women, by nature of being women, biologically, experience illness and disease differently due to the diverse conditions in which they live. There is a saying that poverty has the face of a woman. Women live in different conditions. Women are the poorest among populations, and therefore the conditions in which they live also expose them to conditions or diseases like DM. In resource-constrained countries, and when I talk about resource-constrained countries, our country, Kenya, is among them, and women in rural areas experience a disproportionate burden of disease due to factors such as moral and ethical issues, entrenched cultural practices, gender power relations, and also trust. A decolonization, which here I refer to as a process of conducting research with indigenous communities, was necessary in our study because this places indigenous voices at the center of the research process. Again, in central Kenya, local language or local knowledge was obtained using qualitative techniques which captured different perspectives and lived experiences of women with type 2 diabetes mellitus. I have been in the conference hall from Tuesday to today, and I find that there is a relationship between women in our study and also some topics of interest in this conference. And one of them is that women are at the center of any discussion that is related to gender dynamics. In central Kenya,
Prof, just 1 minute. Did you want to project something on the screen?
Yeah, the media team can do that.
The technical people, do we have the slides from Professor?
So in Central Kenya, women share accounts of resilience, also share accounts of lived realities as a segment of the East African populations. Our main objective for conducting this work was to explore the use of qualitative techniques as methodology in decolonizing anthropological research in the utilization of formal health care services by women with type 2 diabetes mellitus in Central Kenya. Our first specific objective was to establish the extent to which moral and ethical issues influence the health-seeking behavior of women suffering from type 2 diabetes mellitus. The second specific objective was to determine the influence of entrenched cultural practices on health-seeking behavior in the study elements. And the third one was to investigate the effect of power relations and also trust on health-seeking behavior among the study population. So which methods did we use? This qualitative study was part of a larger study that we conducted that aimed to explore the factors determining utilization of formal health care services by women with type 2 diabetes mellitus. It was conducted in 2 public health facilities in Central Kenya, where the dominant ethnic group is the Gikuyu people. We used a local language, which is the predominant language used by the people in Central Kenya, Kiambu County, Central Kenya. And we also used Kiswahili, which is our national language, to collect qualitative data from the key informants. We conducted focus group discussions and also did narratives. The FGDs and the narratives helped us to yield very rich qualitative data. And this, of course, made the participants the main source of knowledge. I hasten to say that knowledge that is obtained this way is culturally appropriate. It is also respectful of the study participants. And when we incorporate indigenous language, which is culturally appropriate, this allows ideas to flow freely from the participants. It is also a way of respecting the study subjects, and this is a core principle of decolonizing research. Anthropological knowledge that is generated using this approach therefore situates the lived experiences of the participants outside of their geographical environment and also reach, and this then This information is shared in symposia, also in conferences like the symposium that we have had here from Tuesday to today. Our study population comprised women aged 18 years or 18 years of age and above who resided in the two study sub-counties where we conducted our study. We used purposive sampling and also convenience sampling to select the samples for key informants, interviews, as well as the FGDs that we conducted with about 8 to 10 study participants. We also conducted narratives, but because those narratives will not fit in the slides, I have them in the full paper. Some of them in the full paper, they do not appear in this presentation. We used key informant interview guides to collect the information on factors influencing use of health services. A focus group discussion guide helped us to collect information on the experiences of women. We also used the narrative guide, a case narrative guide, which helped us to collect information or to do the narratives with 8 women from the the 4 study sub-counties. We also used direct observation, which is a method that we use in research, and we used an observation checklist to help us do the observations that we did during our study. Kiswahili language was used to collect the key informant interviews with the health providers. We also used Gikuyu language, which we used to conduct the focus group discussions and also do the narratives from the 8 women that we studied. So how did we process our data and also analyze it? Qualitative data was analyzed through content analysis. We organized it into common concepts and themes, and that was according to the study objectives that we had set. Our findings indicate that the study participants' age ranged from 18 to 73 years. Slightly more than half of them were married, and most of them, or majority of them, were farmers. That was their occupation. And key informants comprised female and male health providers. Moral and ethical issues that were considered. Moral and ethical issues that we took into consideration included the client-health provider relationship, satisfaction with the services that were offered in the formal public health facilities, and also the attitude of the healthcare providers. The findings for the rating of the health providers and the various services that were offered to the study elements were purely confined to public health facilities owned by the government of Kenya. In one focus group discussion, participants were fully in agreement, and they supported a rating of the client-health provider relationship, and this was their observation. They said that we are treated well when we attend the diabetes clinic. When we ask questions, we get the answers according to the way that we have asked the questions. The doctor who was at the clinic at that time was rated to be good by the participants because of listening to their concerns, and the conclusion that the focus group discussants made was that people are different, and it helps also to understand that people are diverse. We cannot all be the same. That was what the focus group discussants said. What about satisfaction with the health services? More than three quarters of the study participants were not satisfied with the services that they received. 20% were happy or affirmed that they were satisfied. 1% did not respond to that question. What about the perception of attitude of health services or health service providers by the study participants? There is a group, or some of them said that at the hospital, some of the health providers treat them well, others have a bad attitude, and the conclusion of the study of the focus group discussants was that some people are good, others are not so good, and therefore they will not treat those who seek, or the consumers of health care, the way they would wish to be treated. Others said that sometimes they spent a lot of time, many hours waiting to see a health provider or a doctor, and they said that you dare not ask why we have to wait for such a long time in the queue in the health facilities. Why? Because asking such a question they might be given wrong drugs, which then would affect them adversely. How many minutes?
5 more minutes, Professor.
1 moment.
No, 3.
Okay. I will go over the results very fast because of the time that is left. Others said that in another focus group discussion, participants said that health providers treat them well, others are harsh. Sometimes you might ask a question and some just look at you and they don't tell you anything. and they confessed that they use the health facilities because they cannot afford to use the private health facilities because of cost, high cost. What about the entrenched cultural practices? We looked at the educational achievement, and 54% of the participants had attained primary education. Slightly over a fifth had attained secondary school education. Almost 20% did not have formal education. In a higher education or a good educational achievement is a plus because it helps to improve self-management in persons with diabetes mellitus. And that's why we need to take our girls to school. And not just the girls, even the boy child. In anthropological research, self-management means moving beyond extractive practices to non-extractive practices by addressing the need for maintenance of health and well-being. Non-extractive practices or practice is a core principle for decolonizing research that our study considered. In terms of gender, power relations, and trust, that table, okay. There is a table that has not been, okay, there we are. Some of the participants made their own decision to attend the diabetes clinic. Others had to seek permission from their husbands, and also some, because of the dependence on their children for financial support, had to ask for permission to attend the clinic from their children. Decision-making and utilization of health care depends on many people within the family. And I want to read this one about the key informant interviews and what they said about decision-making with respect to utilization of health care. Lack of support from family members and multiple responsibilities at home, such as looking after other family members in the household who are sick, even looking after grandchildren, are some of the experiences that the study elements had. People who should be looked after had the responsibility to look after other family members and hence not attend clinic. Sometimes heavy workload that women have in the household also precludes them from attending clinic or getting health services. In conclusion, I want to say that decolonizing anthropological research using qualitative approach allows indigenous knowledge to be collected. It also benefits participants by using non-extractive practices. It also privileges and respects indigenous voices by local communities. Decolonizing research methodologies using qualitative inquiry is a continuous process which places the voices of individuals as well as communities, particularly women in the rural areas, at the center of the research process.